My name is Far Curlin with Warren, who was up earlier. I'm one of the co-directors of the Theology, Medicine, and Culture Initiative. We're delighted to have you here for the 2026 Thomas Catena Lectureship in Medicine, Faith, and Service. The lectureship, the Catena Lectureship, honors those whose work displays innovative scholarship, service, and institution building at the intersection of theology, medicine, and culture. We seek to honor those who, like Dr. Tom Catena himself, are exemplars of faithful service and to embody and inspire solidarity with those suffering injury, illness, and disability, particularly in underserved contexts. We encourage Catena lecturers to tell their own stories, to tell the stories of how they ended up doing the work they do and what it's been like, and to speak candidly, wherever that makes sense, about the moral and spiritual dimensions of their work, including how the Christian story and the church has potentially mattered for the way they've been formed or for the work they do. And we encourage lecturers to cast a vision for how clinicians and trainees might follow in their paths and join them in the work to which they are committed. So, and we bring that spirit to tonight's event where we're delighted to welcome this year's Catena lecturer, Dr. Jim O'Connell, who has overcome a nor'easter and an airplane mechanical failure to get here to be with us this evening. After completing internal medicine residency at Massachusetts General Hospital back in the 80s, Dr. Jim O'Connell began full-time clinical work with homeless individuals as the founding physician of the Boston Healthcare for the Homeless program. That program now serves more than 10,000 homeless individuals and families each year. With his colleagues, Dr. O'Connell established the nation's first medical respite program for homeless persons, offering medical care that addresses everything from acute illness and injury to palliation and care at the end of life. The recipient of numerous honorary degrees and awards, his work has been featured in feature-length documentaries, including Give Me a Shot of Anything and The Antidote, and several books, including his own book, Stories from the Shadows, Reflections of a Street Doctor, and the New York Times bestseller, Rough Sleepers by Tracy Kidder, who some of you will know for having written also a book about the work of Paul Farmer, Mountains Beyond Mountains. I've been reading that book in preparation for meeting Dr. O'Connell, and I certainly recommend it to you. We're honored to have Dr. O'Connell with us to tell us some of his story and the lessons he's learned while caring for his patients in Boston. So please join me in welcoming Dr. Jim O'Connell.
First of all, there were a lot of misadventures getting here, but just to let you know, there's 3 feet of snow in Boston. The temperature is about 12 degrees right now, and so I'm thrilled to be here. And it is indeed my first time ever at Duke or in Raleigh, so I feel like I've died and gone to heaven here, and you live in such an amazing world. And I also have to offer my thanks. This was a real treat to be invited to give this. It was also nerve-wracking because we don't usually talk about faith and all these things in our world. We kind of keep those hidden. So it's been an interesting and scary opportunity to do that. So I'm going to try to talk about some of the things that have really shaped what we have done in Boston. And if I can remember this, if I hit W, that should come up. So I'm going to just give you a little whirlwind tour, and I have to put my thing on because I know we want to be done in 35 minutes or something, right? So, in all sort of honesty, I had no intention of doing this work at all. It was a complete conscription by my chief of medicine to make me do this for a year. And I remember back at the time he was asking me to do that, I was finishing residency. This was in 1985. And I really wanted to do palliative and end-of-life care and become an oncologist. Had a fellowship, and my chief of medicine had been working with the mayor of Boston, who had received this grant to take care of homeless people. And the homeless folks who had gathered with the mayor insisted that there be a full-time doctor, and they couldn't find one. So I was kind of the low man on the totem pole of the resident. So he delayed my fellowship for a year, and I ended up doing this for a year. And what I wasn't aware of was any of the stuff I'm about to show you. And so please don't take any of this as mine. It's all what I got told to do, often beaten up to do. But the first thing that I had to learn was that the Robert Wood Johnson Foundation gave this grant to mayors of different cities because they realized that while the solutions to homelessness have to be coming from like federal and major changes in our society, the day-to-day problems of homelessness end up on the mayor's desks. So 19 cities got these grants. They were 4-year grants, and Boston was one of them. Just a little aside, it was only open to cities of 250,000 people or more. And in the 6 states of New England, which was the region we were competing in, there is only one, which is Boston. So we were in hot competition with ourselves. But this is a later picture of the group of people that put us together and decided how they wanted to be served, not how we wanted to do it. And I threw this picture in there because I wanted to throw in a little plug for those of you who may know him, but if you don't know Brian Klausner yet, this is Brian's book called In the Gaps. And Brian was a doctor with us, magical as you can imagine, from in the 2000s to about 2007, I guess. And he was like, transformed a lot of what we did in our clinics. And any of you who have worked with Brian, you know how amazing he is. But what's extraordinary about this book, 2 things. One is, this picture is of the homeless people who are currently on our board of directors. And the woman who's in the wheelchair on the right is Brian's patient, to whom he is still devoted. And she gives the white coat ceremony talk at Harvard Medical School every year, often invokes what Brian was able to do for her. It's quite extraordinary. And if you read this, it's a complicated book. It's really good. But in the end, Brian, after going through all the science and everything else, says it's really all about love and how do you love people. But he's had to go, and I can't embarrass him anymore now. But here's what they wanted, and it completely, I had no idea about this, but they decided that they wanted healthcare to be about social justice and not charity. This is 1984. And they got a legal firm to get the chiefs of medicine of the 2 hospitals and the mayor to sign on that this is what we would have to do. And by charity, in their minds, they considered volunteerism charity. In my mind, volunteerism is what we do and we should do and we continue to do. But to the eyes of a homeless person, when they were thinking about their health care, they wanted people to stick with them. They wanted people to be there and not to just show up on a Monday or maybe another Tuesday or something like that. So it completely turned upside down the way we wanted to do our program. The other thing I could give you the others, it was no students because they thought students were learning on them. Their experience was that students would come and do physical findings at the shelter, they would do all this stuff, but then none of the students ever came back and took care of them. So they didn't want to be guinea pigs anymore. They wanted to be just like everybody else. And we also couldn't do research and couldn't do mental health services. And if we had another night, I would tell you why that was happening. Those were all mandates from homeless people and shelter advocates. But what they did say was that we had to work, the whole core of our program was this continuity of care that had to go from shelter and street right through to the hospitals and then eventually to respite care and to housing. And that was what they wanted. They wanted people that would stick with them, but be with them through the continuum of care. Kind of a tall order, since none of us had ever done that nor knew how to do it. Then we had to work in teams. And I throw this in there. These are the last 2 word slides I think I have. But they, believe it or not, this is going to sound crazy, but they hated people like me. I took this job to do for a year. And to me, it was my year of giving back. And I owed that. I was a late 60s graduate in college. And we had a lot of social conscious issues that we were trying to work on. And so I was going to give back. But they saw this as another do-gooder coming from some crazy university who's going to come here and feel good about himself for a year, take care of us, and then go do your life somewhere else. And what they wanted were people that were going to stick with them. They wanted you to choose this as a career, to do this as something you want to. Kind of radical when you think about it, because there were no jobs. When I can remember back then thinking, if I didn't do this particular one, there were no other available jobs for a doctor to be working with homeless people anywhere I could find. So it was sort of an interesting twist and a challenge to us in a way that I hadn't been remembered. So I had to work in a team, meaning that I was working with a nurse practitioner, physician assistant, and a team, and we all had to share equally in the care of whoever we were taking care of. So I had no panel of my own. It was a panel shared by everybody. Interesting thing. And then the last thing they said is we had to come up with a respite care program. That was the 1984 mandate to our program. So what I didn't realize, and this is in the world of self-confessions here, so I had grown up as a kind of a social justice Catholic in a really Irish Catholic town in Newport, Rhode Island. And, and life revolved around the parish. And my parents, my dad had never gotten out of high school, worked a couple of jobs. He was a World War II veteran, but he was dead set on the Beatitudes. That was what made things work. And he drilled them into us, which almost seems like an anomaly when you think about it. But that's what we grew up believing we should be doing, and that's what we aspired to do. And even though we went to church all the time, we didn't talk about it. He never talked out loud about it. So I grew up in this world where we kept our, we didn't talk about our faith that much. We just kind of lived it. I remember that hearing when St. Francis said, go forth and preach the gospel, but occasionally when you have to use a few words, that's kind of the way my dad would have looked at it. Anyway, so when I finished my residency, and I'm full of myself, for those of you who are doctors, by the time you finish residency, my last rotation was running the ICU at Mass General, and you have this huge sense of ego. I can remember thinking it wouldn't have fit into this room back then. And I was going to then, after I finished that, the next day, basically, when I finished the rotation, go down to the shelter clinic and be the doctor in a shelter clinic. And I kept thinking, how hard can that be? I've just managed the ICU. And I went down to this 6 blocks down the street to Pine Street Inn, which is New England's oldest and largest shelter. It had 800 people sleeping there at the time. And I walked in and it was mass chaos. And I had never been in a shelter before. I didn't know anything about homelessness. And I kind of froze because I realized I had no control over anything, nothing. And I walked into the clinic, which was run by these nurses, and you walk in the door and it was kind of peaceful once you close the door behind you. And around the perimeter of the room, the nurses brilliantly invited people in and they would soak their feet. That was how they engaged people. And I thought, this is a little weird. It was incredibly smelly. And I said, well, I can handle this. Until Barbara McGinnis, who was the head nurse there, who, by the way, I should confess, was a third order Franciscan, I learned later on. So they're hidden all over the place. And she said that the nurses had learned two things. She said, first of all, that we had been trained all wrong. That in training, we learned to be fast, efficient, really get to the point, do your exam, do your treatment, and move on to the next person. And she said, if you try to do that here at the shelter, you will never get any homeless person to pay attention to you. And so she said, what you can do, she took away all my stethoscope and all my doctor stuff and said, you can soak feet for the next 2 months and we'll teach you how to do this. And I almost dropped thinking I should be I should be going to my fellowship right now. I'm going to soak feet. And it was brilliant because what the nurses did was invite people by calling them by their name. So they would say, Mr. Williams, can you come on into the clinic? Can we soak your feet? And I wasn't aware at that time, I've become since very aware of it. That's magic. When homeless people hear somebody say their name with dignity and care and kindness, it makes a huge difference. And then when you say, can I soak your feet, rather than, are you having any chest pain? What's your chief complaint? It's, what can I do for you? And then, brilliantly, you're at the feet of the person you're serving. And I realized right then that, I was often about the stethoscope, like away from somebody's most private space. And that's how we're trained. But for many people, that's way too close, especially people that have been scarred by life on the street. So I can remember thinking, this is interesting, and I had to learn how not to ask any of the questions I used to ask, but just ask, is there anything else I can do for you? And for some people, they would look at me for a while and eventually start talking to me. Some people, it took months before I would really even get a chance to see them. But all the time, it was the nurses watching over me to make sure that I understood that you have to earn their trust before anything else is going to happen. So I can tell you the story of this man who was the person I most remember soaking his feet, and that's the oldest picture I have. And he had terrible schizophrenia. He was a paranoid type, and he was considered by our records at Mass General as treatment resistant. Hundreds of admissions to the emergency room brought in by police, never did anything we say. And I was looking at him, and he kept looking, giving me that wry smile. And at one point, he looked down at me and he said, this is about 4 weeks after I've been soaking his feet. He looks down and he said, hey, I thought you're supposed to be a doctor. And I looked up and I went, wow, it's the first person who's even noticed that I'm a doctor. And I was thrilled. And then he goes, well, what the hell are you doing soaking feet? And I had to laugh, and I said, I don't really know him, except I do whatever the nurses tell me. And interestingly, that's what he did. He always did what the nurses told him. He wouldn't do what we said. So we had a bond. And about a week after that picture was taken, he looked down at me one night and he said, hey, doc, I'm having trouble sleeping. Can you give me something to help sleep? And I'm going, here's a man that has been resistant to all this, now asking me for medicine. And within about a month, he was on all the medicines back in those days we wanted him to be on, and that we had spent 25 years at Mass General saying he was absolutely resistant to take. So I realized, you know, like with the bolt of lightning, this is what the nurses were talking about. It's not resistant to treatment, it's resistant to the way we try to treat people. And then I had to have another, after I'm finished soaking feet, I want to show the nurses that I'm a good doctor. I've got to earn my reputation, right? So this man who I grew to love, his name was Amerigo, was one of the people when you had the lobby outside, you could hear his laugh and his screaming above everybody else. He just was that kind of guy, and he was electric. And he came in one night, and he looked at me and he said, Doc, you got to do something. And I said, Amerigo, what can I do for you? And he pulls out his bottle of vodka, and he says, I can't swallow this damn stuff. And I didn't know whether to laugh other than to think, oh my God, if this is serious, this could be really bad. So I asked him what was going on. He hadn't been able to swallow food for weeks, but he could handle that as long as he could get his vodka down. When he couldn't get the vodka down, then he went to see someone, right? So the lesson that we learned, that people don't come to you for preventive care. They come to you when something doesn't work. So we had to learn how to work around that. But anyway, it turns out he had a huge esophageal tumor. It was way past any surgery or radiation we could do. We put in a feeding tube so that we could feed him. And then I spent the whole weekend getting him admitted to a nursing home in the neighborhood he had been born in, South Boston, where there was a really wonderful hospice program. Because we figured he only had I had to talk with him, they only had about 5 or 6 weeks to live. And so I got him in there. I thought I had done my first real important intervention. And I came back to the shelter, whenever it was, 2 days later. And I'm walking down the alleyway and I can hear him laughing, above everybody else. And I walked over to him and there he was. He's talking with all of those friends. He's laughing like crazy. And he's got his feeding tube here and he's pouring the vodka right into his feeding tube. And I'm like, didn't know whether to kill him or to scream or what, but I said, what's going on? And then he sat me down and he said, look, Doc, I appreciate everything you did, but you sent me to a nursing home where I didn't know anybody, and people were sitting around watching TV or looking out the window. These weren't my people. I didn't know them. And so he came back to where he had been for the last 25 years in the shelter and begged us to let him die with his friends. So this picture I love because it's one of the nurses at Pine Street doing the feedings that we would do. It turns out he lived for about 2 months, but he ended up doing his end-of-life care exactly where I thought would be miserable for him. And I realized, as all of us now know all too well, I never thought to ask him what he wanted. I figured out, I knew what was going to be best for him and went ahead and did it. So, huge lesson. This picture is the earliest picture I have of our respite program. It's September of 1985. And those group of people that put us together said, we're really angry with you doctors. You kick us out of the hospital and we're way too sick to be able to go out in the streets. Everybody else gets to go home with a family and visiting nurses and home health aides. We get nothing. And so Governor Dukakis gave us 25 beds in the corner of a shelter. And we started this program absolutely unaware of what we needed to be doing, except we were going to take people out of the hospital and provide 24-hour care for them. And about 3 weeks after we opened that up, this man came in, who I had known really well, and he came in, had come out from the hospital. He's now in renal failure, and he's on ambulatory peritoneal dialysis, which the hospital had done because they didn't think he'd be a reliable hemodialysis candidate. And you can also do this in an ambulatory fashion. But he had no place to go except to the streets, so he came into our respite program. And he turns out to be the first person in Boston who was homeless, known to be diagnosed with AIDS. So September of 1985. And it was, for me, and I had seen a lot of AIDS in the hospital, but not yet in the streets. And it was frightening because we still had absolutely no treatment. And everybody, as far as we knew at that time, went on to die of AIDS. We just didn't know how to stop it. We did not know at the time there were some long-term non-progressives. But anyway, he became the first of what eventually became literally hundreds of cases of homeless people with AIDS, getting sicker and sicker and dying on the streets or in and around the streets. It was, I thought, the worst time in my career. And we literally had no treatment other than to treat each opportunistic infection as best we could. And the suffering that we watched people go through because they were shunned for being homeless and then doubly shunned because they had AIDS, no one would talk to them or go near them. And so I think we learned back then a lesson that I kind of cherish, but I'm not sure I know how to handle, but we knew we couldn't save people. What we could do is treat them and take care of them, and we could address their suffering and try to be part of what they were going through, but we knew the end point was death. And we had to come to grips with that. And it was so much work I can't even begin to tell. Those of you who were around during that time would know. And what we ended up seeing was death all the time. And the ubiquitousness of death among homeless people is really quite staggering. This was one of the early funerals I remember going to of a man who had died of AIDS, had no family, no people. And this was a group of, I think they were lay Franciscans or Franciscan brothers who just went to every unattended funeral and burial. And this is a paupers field in Boston. I learned all about when you don't have anybody and have no money, you get buried in a paupers field. And he had the blessing of having a casket. Most people just are buried with a little, their ashes are buried, and there's a little round coin that says whatever the number is, and that's where you're buried. You go to City Hall and you can read the registry to see where that person is buried in a paupers field. It was, I was stunned by that. Now, at this time, so I'm trying to figure out what I'm doing, and we were so awash in AIDS at the time, and we also had, which I don't want to go into too much, we had this parallel tuberculosis outbreak. It was an INH and strep-resistant tuberculosis. We had 60 cases in the shelter that I started in, and of the 800 people, 40% of them converted from negative to positive in their PPDs. So it was a nightmare. And I realized how useless I was as a doctor because I knew what to do for any individual, but I had no idea how to treat the whole thing. And this Robert Wood Johnson Foundation was started based on St. Vincent's Hospital in New York. I don't know if any of you know, in the Village, and it was St. Vincent's Hospital. And it was really the hospital that took care of AIDS. The Village was a big thing. And it was started by a man named Phil Brickner, who's the man on the right here. He was the chief of community medicine at St. Vincent's, kind of a real interesting, wonderful character. He was Mayor Koch, who's on the left here, his doctor. And you can see that at the time, they had Mother Teresa, and they were opening an AIDS hospice right down, not very far from St. Vincent's Hospital. And that was the first real hospice to open for people with AIDS. And I'll never forget going down there. Phil had asked us to go down. We were trying to learn everything we could. And it was a real awkward experience for me because I cherished Mother Teresa for what she was doing. But when we went into the hospice, these were, kind of rugged people from the streets. And, there was no card playing, there was no music, there was no TV. It was a lot of seriousness. And the contrast between the kindness and the holiness and the lack of fun was really awkward. And I remember talking to Mother Teresa about that, and she just said, she was really cool about it. But most of the people we take care of in Boston would never go to her hospice. It's a different thing. So we had to learn, how do you walk that fine line between what is needed, and how do you keep it lighthearted and allow people to be whoever they are. So that AIDS epidemic sort of, and that whole thing defined a lot of how I started early. I mentioned earlier today that almost every one of the nurses and the people that were working in the shelters, we do the clinics in about 30 some shelters around Boston now, but in the early days, almost everyone was like a Catholic worker or a lay Franciscan. I mean, it was all underneath. There was a real spiritual bent to it all, but none of them would talk about it. It was all, they did their work. I remember one time Barbara McGinnis asked me early on, she was a little suspicious of me when I first got there, and she said, "You want some kind of saint or zealot, are you?" And I kind of went, my God, I'm a 37-year-old dropout from everything. I'm not a saint or a zealot, I'm a bartender. And she went, "Thank God." She said, "They're impossible to work with." So I remember thinking, okay, even if you felt that way, you would never show it. So anyway, now I'm going to show you just a little bit of what emerged from all that, from my perspective. And it said, how do you live quietly your faith and understand how the medicine that we were doing, in my case, medicine, how it could help work that out. And I remember that this slide, which shows the lost souls, we have in Boston shelter beds for virtually everyone. 97% of everybody who's homeless tonight in Boston will be in a shelter. And only about 3% will be outside, and we call them the rough sleepers or the lost souls. And they are and those are people who could go in. There is a bed in the shelter for them, so they don't go in for a whole bunch of complicated reasons, which I'd love to talk to you about sometime, because I've stopped asking people why they're out because it's so complicated. But what we realize is that first winter, the people who lived outside, the small number, had by far the greatest number of deaths. And while we had done a great job, we thought of getting to the shelters, and we had our hospital clinics going, we got our respite program going, but we were not getting to the people on the streets. So in early 1986, or winter of 86, we started realizing we had to get out to the streets and take care of people there. And the Department of Public Health gave us money for a van. This is a public health department, for a van to go out every night in Boston from 9 at night till 5 in the morning. And on this van, I'm going to show you, this is the story. I'm going to tell you, this is Michael, who I met the first night I worked on this van in 1980, this would be January of 1986. And Michael was a street guy, delightful guy, very proud of his street smarts. He walked around all night, he knew everybody. And we used to look forward to running into him on the van. And I think the van, just to let you know, the van looks like this. It's not a medical van. I tried hard to get everybody to make it a medical van, but the homeless people who were involved in doing this said they don't want doctors and nurses in the middle of the night. They want soup, blankets, sandwiches. They want stuff. So the van brings that stuff to them every single night. And to this day, it's been 7 days a week for all these years. And they know the people that work, the heroes in my story, the real saints here, these folks who nobody ever sees them. They work they're full-time employees, they're not volunteers. And they know everyone out on the streets. Most of them have been homeless themselves or in recovery, and a singular thing about them is they never judge anybody. And so I remember as long as I buy the coffee, I've been able to ride on that van 2 nights a week for whatever it is, 40 years. And that's how I've gotten to know everybody who lives outside, or at least most people who live outside. And this is a cold night. This is Trinity Church in Boston. There's still, this was 5 degrees outside. There was still 100 or 200 people sleeping outside in that weather. I threw this picture just as a couple of examples. It's a 92-year-old woman who stayed outside all one winter. And I tried so hard to get her to come in. And she's the person that to this day haunts us about, when do you bring somebody in against their will when you think they're in danger, or let them make their own choices? And that vibrates every day in our world, and I'm sure if you do this work, the same thing. Making sure people are allowed to make their own choices, but when is that a rational choice? Anyway, so we went out. What I learned about Michael on the van is that I realized he couldn't read or write. 25% of the men living on the streets of Boston cannot read or write. Okay, so when you start to ask why are people homeless, you have to go way back, usually 30, 40 years, and realize what they lived through in foster care or in their families or in bad schools, not when I say bad, underfunded schools, and people with ADD, people with learning disabilities, people with IQ deficiencies, etc., all could have escaped care during those days. And I think to this day, in inner city schools, that happens a lot. But anyway, Michael had been grown up here in North Carolina. Someone had been murdered in his presence. I don't know whether his mother or his father, he never talked about it. And he was sent to family up in Boston. And at the age of 14, he became homeless because he just couldn't handle that. And he never learned to read or write. So he was 14 when he first became homeless, believe it or not. And this is him now on winter day. But now we decided going out at night wasn't enough. We better get out during the day when we can have services around. And one of the joys of my life now is that the team that I get to go on, and please understand this is the evolution of many years, but it's been since 1986 that we've had this team. That we have a psychiatrist. The woman in the red hair is a psychiatrist who I think is the first full-time street psychiatrist in the country. She's going to retire soon after 25 years with our program. There's a therapist in the red, and then I'm there. So we get to go out together. It's medicine and psychiatry, and usually someone from addictions. It can be together. So when you're outside, you don't refer people. It was a brilliant move by somebody, and the best way to do life. This is Dave Bunsen, who's half my age and now running our team. He's trained at MGH. I say that half my age with great bitterness, by the way. But we had to learn from our nurses that much of what happens on the street, this came up a little bit, is not just first aid and episodic care, but you can manage chronic disease, you can do all sorts of stuff if you are consistent. And we learned on our team you have to be full-time. It's best to be full-time and do it as your full-time job. And because this is a really complicated population. This is a woman who's 82, has terrible heart failure, won't go to the hospital until she's in pulmonary edema and gets brought in by ambulances, but she will let us do all of her heart failure treatment at South Station, which is our Amtrak station, including, we can draw her bloods, you can listen to her lungs, you can change her medications, and she's so happy to talk to us that for about almost 10 years, I'm sorry, she was 82 in this picture, but for the years before and after that, for about 10 years, we were able to manage that all right there. Always getting on the phone with the heart failure clinic at the hospital to say, are we doing the right thing here? And it was kind of a nice collaboration. She ended up dying in a nursing home not long after. But we started to realize you can do a lot of stuff out on the street that we used to think had to happen in a clinic. And I would urge you to think that what goes on in your exam rooms that couldn't go on at a McDonald's with a little privacy, and it's surprising. I didn't believe this, but our nurse practitioner convinced us of this. And then we never know what the right outcome is you should be looking at, because what is the outcome of getting to know people and walking with them? Are you changing medical outcomes? I want to say yes, but I'm not always sure you do. Some people are not interested in that. But one thing that was really cool is when it came time for flu shots and vaccinations and stuff, most of our folks will say yes. And this is in the first couple of weeks that we had COVID vaccines. And we would bring them out to the folks on the street. And while none of them would ever go to CVS and want to go to the hospital and get a shot, if the person they knew said, I have a shot here, do you want it? We had almost no one say no. And I realized that was just, they trusted the person who was there giving them the shot. So sometimes I think the healthcare system can learn a lot from what these folks are teaching us. That's a little park, by the way, it's on the grounds of Mass General. Now here's Michael. I'm going to frame shift it. The first picture was in '85. The second picture was in 1994. This picture is now in 2001. And he's now stands outside of Starbucks, and he knows everybody coming and going. He knows their names, knows their kids' names, and he's brilliant, and he gets money. That's how he makes his living. And he's a guy who can't read or write, but he's got such smarts. But now he doesn't like us stopping and seeing him there because he's got business to do. So we have a clinic at MGH, which is dedicated to the street folks, which is only a few blocks from where he is. So he would come to a clinic. So we realized, going back to that original principle, you can do a lot out on the street. Paul Farmer taught us this as well. You can do a lot out in the community, out in the street, but when you're finding people that are really sick, you need a system. You need to be able to get people to, specialty care. You have to get imaging. You have to then do care over time for people that are really sick. So the clinic at MGH, which I thank MGH, we have one at Boston Medical Center as well, that it actually was kind of cool because this hospital said, we'll forgive people having to come in off the streets. They can't shower, they can't do anything. So they gave us a special waiting room. Now we have our own clinic. And I love this nurse taking vital signs. And if you look carefully, a medical student pointed out to me that somebody's sleeping under the table there. You can barely see him. So it's a little outrageous, but it's really fun. And we were worried at first that no one would come in. Who's going to come to the hospital or the clinic? And nobody cares whether it's Mass General or Boston Medical Center. They care about who they're going to see. So if you see somebody outside on the street, we realize, and you could say, will you come see me tomorrow? I'll be here, come anytime during the day. Or in this case, our nurse practitioner. So now we see 70, 80, sometimes 90 people on a morning from the streets in that clinic. We can't handle it, it's too busy. But it's a social event. People come, can get away from the cold or the heat, and we have donuts and coffee, and we have meal tickets, and it's a real event. And it allows us to take care of all of the, we can get into the specialty clinic, do all the stuff that we really need to do. We don't have much room. That's a psychiatrist who just takes a table at the cafeteria and he sees people right there because we don't have a separate room for him. And then it's a great place for students and nurses and all sorts of stuff. And this is one of our patients on Valentine's Day. I don't know why he picked yellow flowers, but he did. And that picture is particularly poignant to me because he was stabbed to death about 5 days after that at a Celtic game by a friend. It just happened to be an argument, and he was stabbed to death. Now this is Michael, and I'm going to frame shift now. This is now another 5 years down the line. I'm telescoping this in a big way, but I hope you're getting that as we've gotten to know him, we came to cherish him. And I think he really depended on us showing up and being there. But I'm seeing him, this is at Starbucks, and he looks terrible. So this was at the end of a day, and I said, Michael, you sure you're okay? And he said, no. And he agreed to come over to the clinic. And he came to the clinic and had huge lymph nodes over his clavicles. And it ended up he has prostate cancer that is metastatic just about everywhere. So we brought him to our respite program because now he needs, we brought him upstairs to the cancer treatment place and did the whole diagnostic thing that same afternoon. And then we brought him over to McGinnis House, which is our respite program in this building, right across from the emergency room. And he came over, and I'm feeling terrible. This is a guy I've known now for 35 years, and always a live wire, always great to see. And I think this is awful. He's probably going to die eventually from this. So we get him to McGinnis House, and I walk in to see him, and there he is, smiling like a storm. And that's with Julie, one of our assistants, and one of our nurses right there. And he looks at me and goes, Doc, this is the best. And I'm ready to cry, And he said, look, I've got these two great nurses, and I've got a TV here, and they're bringing me meals, and I've got a bed. And he didn't care about his cancer. He was just so focused on what was going on right now. So we got him through the first round of stuff, and he went into remission. And during that time, when he went into remission, we moved him we have a step-down respite program where we learned a lot about him, including that he loved animals. And our social workers were able to he's now 62 years old, right? And we were able to get him to sign a lease for an apartment, first apartment he's ever had. And it's in elderly housing, great place. And he's pretty happy about it. So I brought him over. We brought him to his housing, but he wouldn't let me bring him there until we stopped by the shelter and pick up a cat. And so I'm like, Michael, let's go do this. But he needed a cat. I think if you look carefully, that cat isn't so happy to be with Michael, but it really was. And then, so we got him into his place, and he doesn't have very good taste, but he got to pick out furniture from the furniture bank. And now he's living by himself for the first time ever. And I told people today, the first call I got in the middle of the night was from a really angry Michael who was trying to figure out how to work the clicker for his flat screen TV. And I said, Mike, I'm supposed to be your doctor. And he said, well, you know this stuff. What are you going to do? So anyway, we learned when people get into housing, they didn't want to lose their connections. And when you do go into housing, you frequently are in a new world with no one you know. The community you knew, the skills you had don't work anymore. So we've learned through the people that are on our board of directors, the homeless people, that we are not allowed to abandon people when they get into housing. If they want us to continue to follow them, we do home visits. And we would do a lot to Michael. I can tell you all sorts of crazy stories about it. But to fast go, he lasts about 2 years in remission. And now it's come back and it's pretty vicious. And so we brought him back to MGH. Now he's going to do this salvage chemotherapy, but it does not work. This is Becky, our nurse. One of the things we have to do is pick him up each day and bring him over his chemo and all that. And he did the same thing in chemotherapy. I'm feeling terrible for him, but beautiful nurses, he would say, and there's a flat screen TV again, and he had the best food ever. So I kept having to frame shift my own thinking. And then he's now about a week away from dying. And I'm really worried about him. He's in agony because the cancer is all through his bones and he's got bone pain. And he won't let us bring him in to give him some heavy duty pain medication that we could monitor. And the reason he won't come in, as you guys can probably see, is he doesn't want to leave his cat, right? So our physician assistant, whose name is Jen Nunes, was with me on this visit, said, Michael, I'll take the cat for you. And so he took the cat and he agreed to come to the hospital, and we admit him to the hospital to get a sort of basically end-of-life comfort care. And so the next day, we get him into the hospital. Next day, and I'll end here, he calls me up. I'll never forget this. And he goes, hey, doc. And I said, yeah, what's up, Michael? He said, you got to get me a Big Mac, but no lettuce, absolutely no lettuce. And can you get it for me before the morning's over? So I said, sure, I'll try to do that. It's hard, by the way, to get a Big Mac with no lettuce. It takes time. But I brought it over to him, and I'm worried about him. You know, he's ready to die. So I bring him into the room at Mass General, and he looks like he's in extremis, right? And I said, Michael, you sure you want this sandwich? And he sits up, and this is my last picture I have of him. He's 1 day away from dying, 1 day. And he just sat up, and he was so thrilled to smell and touch and lick this sandwich. He couldn't eat it. But he taught us this lesson that I think we've been trying to learn all along, is that he didn't care. He just wanted to find whatever joy he could in the moment. And he wanted to have the people he cared about with him in that moment. And I think all of our staff kind of just were stunned by that joy in the midst of a guy who was given nothing in this life, absolutely nothing. And so I think what we learned is he gave us a whole lot more than we ever gave him. And I think that's a theme that all of you who take care of people like this probably know. And this was his service when he died. We have services all the time. This is at that same park. And what was interesting, it's like the police, the police are there because they knew him. The service is being done by the Cathedral of St. Paul, which is the Episcopal Cathedral there. And then it's a mixture of homeless people and staff, it's both Boston police and the MGH police, and it just felt like the right thing to do. And we kept wishing Michael could be there to see all the people that cared about him and loved him. So I think I could go on, but I'm going to leave it. This was the tree where everybody puts a flower and we have the services and do that. And I think I'm going to stop because I'm over time. But I could give you a few more stories, and if we ever have time, I'd love to sit down with you and go over the ones that are more problematic and much more difficult. But if I could say anything, I think we learned, and by the way, spent a lot of time talking to Paul Farmer, who came to us as a student and helped us with our TB outbreak. And thank you to Duke for sending him to us. But I think what we learned is it's all about accompaniment. You can put it all into the continuity of care we were talking about, really translates into accompaniment and being there with people, just learning to be present and not push them past what they want to do, accept whatever it is they want to do, but then offer them the best of care that you can, is kind of what summarized it all. And this, I believe, that's the tree in the middle of the park that we considered sort of sacred territory at MGH, memorializing all those folks. But let me stop here. I just want to say thank you, and I know we've got lots of questions, and at least I hope we have lots of questions, but thank you very much. I really appreciate it.